Hello, everyone. We thank you for joining us for today's webinar sponsored by J.J. Keller. Just letting you know as you file in, you are in the right place. Just going to allow about another minute or so for everyone to get in and get settled. But again, we thank you for joining us. As everyone files in, just want to say hello and welcome you to today's webinar sponsored by J.J. Keller. You are in the right place, just allowing about another 20 or 30 seconds before we get going as everyone gets in and gets settled. All right, well, an official hello now, everyone, and welcome to today's Safety and Health Magazine webcast, Bloodborne Pathogens Terminology, Exposing the Regulation One Term at a Time, sponsored by J.J. Keller. My name is Kevin Drewley. I'm an associate editor with Safety and Health Magazine, and will be moderating today's session. Thanks for joining us. We hope you all are doing well. In a few minutes, we'll start our presentation, but first, let's review some preliminary items. The views of today's speakers and organizations are their own and may not necessarily reflect those of the National Safety Council or Safety and Health Magazine. Any mention of a commercial enterprise, product, or publication does not necessarily mean the council or magazine endorses those items. At the end of today's webcast, we'll conduct a question and answer session. To ask a question, simply click the Q&A button at the bottom of your screen, type your question, and click the send button. Feel free to ask your question at any time during the presentation. You don't have to wait for the question and answer session to begin. We'll try to answer as many questions as possible, but because of the large number of participants today, we might not get to every question. Any unanswered questions will be forwarded along to our speakers. At the end of the webcast, you'll be asked to complete a brief evaluation survey, and we'll let you know more about that after the presentation. This webcast will be archived, so you can access it after today's live event. To view this webcast and all of our past webcasts, please visit safetyandhealthmagazine.com/events. With that, let's go ahead and get started. Our speakers today are Tricia Hodkiewicz and Rachel Krubsack. Tricia has been an EHS editor at J.J. Keller since 1994. She provides content for manuals, handbooks, videos, signs, training materials, and online solutions. Her duties include writing a newsletter covering the latest news from OSHA, the Environmental Protection Agency, and the Department of Transportation. Rachel is also an EHS editor at J.J. Keller, and her duties include writing a monthly newsletter on OSHA safety training. Her topics of expertise include hearing conservation, training requirements, bloodborne pathogens, emergency action plans, and hazard communication. Again, we thank you all for tuning into this presentation today. Tricia, whenever you're ready, go ahead and take it away.
Oh, great, Kevin. Thank you very much. And welcome, everyone. So today's webcast is sponsored by J.J. Keller Training. J.J. Keller Training Solutions cover a broad range of topics and are available in a variety of formats. Training on demand, DVD, streaming video, and video books. All of these to help you meet your needs. Backed by regulatory experts and using the latest technologies and techniques, our training solutions give your employees the proper instruction they need. On behalf of our sponsor, thanks for joining us today. Okay, so bloodborne pathogens. The bloodborne pathogen standard at 1910, the 1030 defines 28 terms in its definition section. So the use of these words and phrases may make this regulation a challenge for employers. Today, we will start with the definitions provision and turn to terminology related to some basic terms first, and then we'll talk about terms related to the topics you see here. And throughout the webcast, we define terms colored in blue. And also be aware some images will show what looks like blood. So please chime in through the attendee chat feature today. A bit of caution, the chat feature can be viewed by everyone. So also we won't be searching for compliance questions from the chat. Instead, the Q&A box comes to us directly, and so please use the Q&A feature for your compliance questions to us. And so they really don't get lost in the chat. All right, and we also plan to pose some poll questions that will pop up on your screen. So please use the attendee chat at this time to tell us which word or phrase is the most confusing to you. Put another way, which one gives you a headache? And we have some bloodborne pathogens terms related to our webcast today. The words and phrases are on the slide, but there are also some other possible terms that may have some confusion for you. So feel free to enter a custom answer if you want. I'm going to take a look at the chat. Wow, parenteral, you bet. We don't use that word every day. So I could, exposure control plan, disposal, universal precautions, Sharp's injury log. Right, that's a good one. That's important to know about as a record. Disposal, OPIM. I can see OPIM. We're familiar with blood, but what is an OPIM? We're going to go over that today. Occupational exposure, that's really key to the applicability of the rules. So important to know that. And the list goes on. I see all the terms on here are pretty much what we're going to cover today. Decon, you bet. So let's, fantastic participation, everyone. Thank you. So we're going to cover these terms and more today. And we will close the chat in about quarter after the hour. So, about 9 more minutes. And so in that way, we will be able to focus our attention on the compliance questions that are in the Q&A box. So please submit your questions in the Q&A instead of the chat. So let's dig in here. OSHA offers the definitions in paragraph B. Some of the definitions are explained in an OSHA directive, CPL 02-02-069 for clarification. Also, the OSHA letters of interpretation and preambles may help you understand terms. 1910.1030 applies to all occupational exposure to blood or other potentially infectious materials in general industry and shipyards. And Rachel will unpack some of the terms on this slide. Rachel.
All right. Yes. Thank you, Tricia. And hello, everyone. We're glad to have you with us today. So the most basic term in this regulation is, of course, blood, which means human blood components, and products made from human blood. Animal blood is not covered in the regulation. OSHA gives examples of human blood components, and we've listed those here. Bloodborne pathogens are microorganisms present in human blood that can cause disease in exposed humans. While HBV and HIV are identified in the standard, the term includes any pathogenic microorganism that's present in human blood and can infect and cause disease in persons who are exposed to blood containing the pathogen. The CPL that's listed on the slide here lists 15 diseases related to bloodborne pathogens. The regulation uses the phrase other potentially infectious materials, or OPIM. Only certain body fluids or tissues are considered OPIM, as shown here. We get questions about handling urine samples or cleaning up vomit. Scientists don't consider these fluids to be efficient modes of HBV or HIV transmission, so you won't see urine or vomit under the definition of OPIM. You also won't see feces, nasal secretions, sputum, sweat, or tears. Saliva, too, is not covered unless it's involved with dental procedures. However, if any body fluid is visibly contaminated with blood, it would be covered, even if the body fluid is not listed for OPIM. So if a urine sample is contaminated with blood, it is OPIM. Back to Tricia.
All right, thank you. Excellent, Rachel. So exposure or exposed means a worker is subjected to a toxic substance or harmful physical agent, and this includes biological agents, in this case, a bloodborne pathogen, in the course of employment through any route of entry, and it includes past exposure and potential or accidental exposure. Even with protections, your workers might still have an exposure incident, which means a specific eye, mouth, or mucous membrane, non-intact skin, or parenteral contact with blood or OPIM that results from the performance of a worker's duties. Mucous membrane basically means the inside of your nose or mouth or in your eye, Blood or OPIM that splatters into your nose, mouth, or eye is considered an exposure incident. By non-intact skin, OSHA includes skin with dermatitis, hangnails, cuts, abrasions, chaffing, and so on. Parenteral means piercing mucous membranes or the skin barrier, such as by needle sticks, cuts, or abrasions. And this includes human bites that break the skin, such as maybe encountered by prison guards and police, or in an emergency room or psychiatric ward. So 1910-1030 applies to occupational exposure. Now, an exposure incident is actual contact only, but occupational exposure is reasonably anticipated contact with blood or OPIM. In addition to being reasonably anticipated, the contact must result from the performance of a worker's duties. You would not reasonably anticipate an office worker to have contact with blood or OPIM. However, if you designate that office worker to perform first aid involving blood-related injuries of coworkers, now that worker does have occupational exposure. Job duties don't need to be healthcare related. Manufacturers, services, retailers, warehouses, and other industries may be covered or may have covered workers. OSHA does not tell you what jobs or tasks are covered, so you have to make a determination whether your workers have occupational exposure by definition. The occupations on the slide may have occupational exposure, but not necessarily in all cases. You make that determination. Good Samaritans don't have occupational exposure. Assisting a coworker who is bleeding would not be occupational exposure unless the worker providing assistance is a member of a first aid team or is otherwise expected to render that assistance. So employee under the standard means an employee with occupational exposure, full-time, part-time, temporary, or contracted. A worker is covered if he or she has occupational exposure. Today, we will just refer to employees as workers. So the employer can be large or small, but 1910-1030 only protects general industry and shipyard workers. For construction, OSHA relies on the provisions that are listed on the slide to make sure construction workers are protected. And first aiders at construction sites are expected to receive basic instruction in bloodborne pathogens, hazards, as well as vaccination and follow-up in the event of an exposure incident. Appropriate personal protective equipment, waste containers, and signs and tags must be provided for construction. And so we will not touch on construction regulations today. Instead, we will stick to 1910-1030 for general industry and shipyards for the remainder of the hour. If 1910-1030 applies, you'll have to make an exposure determination. This determination is based on the definition of occupational exposure without regard to personal protective clothing or equipment. You'll review job classifications at your site and make two lists. The first list includes job classifications in which all workers have occupational exposure, like operating room scrub nurses, right? For these jobs, it's not necessary to list specific work tasks, just list the jobs. A second list will include those classifications in which only some workers have occupational exposure. For these cases, specific tasks and procedures causing occupational exposure must also be listed. So perhaps only some of your custodians are assigned to the task of handling blood spills, while others are not. You would list custodians in the second list and then list something like cleaning up blood spills under that job class as the task. All right, Rachel.
Okay, thanks, Tricia. So once you know who has occupational exposure, you must train those workers under paragraph G of the standard. Information and training must be provided at the time of initial assignment to tasks with occupational exposure. It must be given at no cost to the worker during working hours and at least once a year after that. You'll need to do more training if you modify existing tasks or you add new tasks, and these changes or additions affect your workers' exposure. Annual retraining means at least once every 12 months within a period not exceeding 365 days. If the annual training cannot be completed by the anniversary, you should maintain a record saying why the training is delayed and when the training will be done. OSHA says the information you provide must be appropriate for your trainees as far as education level, literacy, and language. The regulation lists 14 training elements. 2 of the elements call for a general discussion of bloodborne diseases with specific emphasis on the epidemiology, symptoms, and modes of transmission of HBV and HIV. Epidemiology has to do with the prevalence and causes of a disease. Modes of transmission relate to the route in which a pathogen is spread. You must convey the idea that a number of bloodborne diseases other than HIV and HBV exist, such as hepatitis C. But at the same time, you don't need to cover uncommon diseases unless it's appropriate. For example, for employees working in a research facility with a particular pathogen. During training, it's critical that trainees have an opportunity to ask questions and receive answers where material is unfamiliar. Trainees must have direct access to a qualified trainer during training, but the trainer doesn't need to be in the room. Trainees can simply have direct access to a trainer by way of a phone hotline. Email is not considered direct access unless the trainer is available to answer emailed questions at the time the questions arise. You'll need a trainer that's knowledgeable in the subjects covered by the 14 training elements. Now, this trainer must also be familiar with how the training elements relate to your workplace. The standard does not define workplace, but under other OSHA standards, workplace means an establishment, job site, or project at one geographic location containing one or more work areas. You don't have to have a healthcare professional do the training. But if an OSHA inspector finds training deficiencies, the inspector will look at the specialized courses, degrees, or work experience of your trainer. If there's no one qualified at your location, you may need to send workers out to get trained or bring a trainer in. Computer-based training or video-based training are both good training tools. However, they're both, they're alone, they're not sufficient because on their own, because the standard requires trainees to have an opportunity to ask questions, and you must cover site-specific information like the location of the plan and how to report an exposure incident.
Okay, wait a minute here. I'm up. So how can you be sure you're meeting all the OSHA's training requirements or that you're covering everything? Give your employees the knowledge to protect themselves from potential exposures with the J.J. Keller Bloodborne Pathogens training program. Whether you need to train on a few topics or many of them, J.J. Keller Training offers a full library of online training courses and pay-per-view streaming videos. If you want more information on the courses we have to offer, let us know by using the poll on your screen. Okay, and as a thank you, we'll send you our Bloodborne Pathogens white paper, and I don't want you to miss that. So we'll give you some time to make your selection. So I think I will take a couple questions, Rachel. Someone asked in the chat about, trained first aiders. Do they have occupational exposure simply because they're certified in first aid? And the answer is, well, it depends. At your work site, do you designate all of them to handle first aid? Or maybe you designate a small pool. It all hinges on their job duties and whether you designate or expect your employee to have reasonably anticipated duties that involve reasonably anticipated contact with blood or OPIM. So you could literally train all of your workers or have all of them certified in first aid. That doesn't make them covered by the rule unless you have designated them. And I suggest if you do train all of your workers in first aid, at the same time, maybe you designate a small pool to handle first aid. It's wise to tell all the others that are trained in first aid, okay, if they come across a blood-related incident, go reach out to the designated first aider at your site when they come across that. So that those other first aiders that simply have training and are not designated won't have occupational exposure because you don't anticipate them to have those duties, right? I hope that makes sense. Great question. I think we can move on to our next slide. All right, so the measures listed on this slide are intended to help prevent and control the spread of bloodborne pathogens. Hepatitis B is a liver infection caused by the hepatitis B virus, and the best way to prevent hepatitis B is by getting vaccinated. The hepatitis B vaccine stimulates the worker's immune system to protect against the virus. After the vaccine is given, the body makes antibodies that protect the worker against the virus. And of course, an antibody is a substance found in the blood that's produced in response to a virus invading the body. And so these antibodies will fight off the infection if a worker is exposed to the hepatitis B virus in the future. And the CDC does say that the hepatitis B vaccine is safe and effective. The vaccination must be at no cost to the worker. Among other things, there's no out-of-pocket expense to the worker. You may not permit the worker to use health insurance to pay for the vaccine unless you pay all of the cost of the health insurance and there are no deductibles, co-payments, or other expenses. You cannot have any reimbursement programs, and a waiver of liability for any harm caused by the vaccine is also prohibited. The vaccine must be provided at a reasonable time and place. Medical procedures and evaluations must be convenient to the worker, normally offered during the worker's scheduled work hours, and if travel is required, the employer must bear the cost. The vaccine must be performed by or under the supervision of a licensed physician or other licensed healthcare professional, and that's a person who's legally permitted to whose legally permitted scope of practice allows the person to independently perform the vaccination. And finally, vaccinations need to follow the current recommendations of the U.S. Public Health Service, and this simply means the CDC guidelines.
Okay, so the vaccine is made available to occupationally exposed employees within 10 days of initial assignment and if they experience an exposure incident. But the worker has the option to decline the vaccination and follow-up programs. Medical informed consent forms are okay, but not required. Consent forms that require a worker to release test results to the employer, waive liability, or exaggerate the hazards of the vaccine violate the standard. First aid is often a collateral, not a primary duty of a worker. But if you fail to provide the vaccination to these folks, OSHA can cite you but won't fine you. But the catch is you have to address these types of first aiders specifically in your written plan, track first aid events, train first aiders to report the first aid events, and make the vaccine available within 24 hours of a first aid event, regardless if an exposure incident occurred or not. And this is spelled out in the CPL that we mentioned. Employers must ensure that workers who decline the vaccine sign a declination form. The language is set forth in Appendix A to the standard. Using a form which conveys the same information as Appendix A but with different words may be considered a de minimis violation. Any additions to the language should be made only to improve comprehension. The form must not add language that would discourage worker acceptance of the vaccine or add liability concerns. If you add information that requires the worker to provide confidential medical information, either on the declination form or on a separate form, a citation may be issued. A worker who signs the declination form may still request the vaccine at a later date, and you would have to provide it if the worker still has occupational exposure. The regulation says that the employer shall not make participation in a pre-screening or antibody testing program a prerequisite for getting hepatitis B vaccination. You can make antibody testing available at no cost to workers. If that antibody testing reveals that the worker is immune, you don't have to make the vaccination available. However, if a worker declines the pre-screening, then you must make the vaccination series available to the worker. You also cannot require a post-vaccination titer unless the CDC calls for it. CDC guidelines do in fact recommend this titer for for a healthcare professional. For boosters, the regulation says if routine boosters are recommended by the U.S. Public Health Service at a future date, they must be made available. However, right now, the CDC does not recommend them, so OSHA does not require booster shots. The CDC is studying people vaccinated at birth to determine their duration of vaccine-induced immunity.
Great. Thank you, Rachel. So the phrase universal precautions means workers need to assume that all human blood and OPIM are infectious, and it doesn't matter who's known to have diseases or not. All right, so body substance isolation is a control method that defines all body fluids and substances as infectious. And so BSI is an acceptable alternative to universal precautions, provided you adhere to all the other provisions of 1910 to 1030. Standard precautions represent the minimum infection prevention measures that apply to all patient care, and that's regardless of suspected or confirmed infection status of a patient in any setting where healthcare is delivered. Standard precautions include the practices on the slide, and these are more stringent than universal precautions and would be acceptable to OSHA. Rachel.
All right, so at this point, let's take an interactive poll to see who's joining us today. Now that you've seen a lot of terms so far, we'd like you to tell us, how would you rate your own knowledge of the bloodborne pathogens terms? So you've got a few options here. 1, you're aware of bloodborne pathogens terms. 2, you have a functional knowledge of bloodborne pathogens terms. 3, you have advanced knowledge of the terms. And 4, you're an expert in the terms. So rank yourself, and we'll share the results in just a bit. And this will go quickly. We have covered a lot of basic terms so far, along with the terms related to exposure determination, training, vaccination, and universal precautions. And there are certainly more terms to come. But again, rank yourself 1 to 4, with 4 being the highest knowledge of the terms. And I will give you a few more seconds here to lock in your answers. So please rank yourself at this time. Okay, I think we are ready to see what we have for our results here. All right, it looks like about 51% of you say you have a functional knowledge of the bloodborne pathogens terms. Let's see, about 26% have a rating of 3 with advanced knowledge. Rating 1, aware of the BBP terms, is about 20%, and 6% of you would consider yourselves an expert in the terms. That's great. That is great participation. So no matter your level of expertise, we do hope you come away from this presentation knowing more. So let's move on now to some more bloodborne pathogens terms. So we'll talk about sharps now. A sharp is an object that can penetrate the skin, including, but not limited to, the items listed here on the slide. So this can include box cutters, razor blades, and knives. These are all sharps. So sharps are not limited to needle sticks. Engineering controls reduce worker exposure by either removing or isolating the hazard, or isolating the worker from the exposure. A commonly recognized engineering control is a sharps disposal container for contaminated needles or other sharp instruments. Sharps with engineered sharps injury protections means a non-needle sharp or a needle device with a built-in safety feature. Needleless systems do not use needles, as the term implies. Proper work practice controls alter the way in which a task is performed. One work practice is having employees wash their hands when they remove gloves and as soon as possible after their skin contacts any blood or OPIM. Also, if you have equipment that gets contaminated, you must examine it prior to shipping and, if necessary, decontaminate it unless you can show that this is not feasible. Because so many medical professionals have had needle stick incidents, OSHA frowns on a number of things when it comes to needles, like recapping and so on.
Great, thank you, Rachel. So hand washing facilities need 3 things: an adequate supply of running potable water, soap, and single-use towels or air dryers. Potable water means water that meets the drinking water standards. Hand washing facilities must be readily accessible to workers, and that's because hand washing must be performed as soon as feasible to adequately flush contaminated material from the skin. Antiseptic hand cleansers in conjunction with a clean cloth or paper towels or antiseptic towelettes are examples of acceptable alternatives to soap and running water. But now these alternatives are only acceptable at sites where it's infeasible to provide soap and running water, such as a crime scene, traffic accident, or fire scene. And when alternatives are used, workers must wash with soap and running water as soon as feasible. Personal protective equipment is specialized clothing and or equipment worn by a worker for hazard protection. And so general working clothes are typically not considered PPE. OSHA only considers PPE appropriate if it does not permit blood or OPIM to pass through to or reach work clothes, street clothes, undergarments, skin, eyes, the mouth, or other mucous membranes under normal conditions of use, and for the duration the protective equipment will be used. When there's occupational exposure, you must provide PPE at no cost to the worker, and you want the PPE to fit. If PPE does not fit correctly, it could cause tearing or inadvertently expose skin, or workers might refuse to wear it. So there are extraordinary exceptions to wearing PPE, but you'll want to carefully read these exceptions in the regulation. In general, PPE is expected to be used whenever occupational exposure may occur. Gloves of appropriate sizes must be made available. So gloves shall be worn when it can be reasonably anticipated that the worker may have hand contact with blood, OPIM, mucous membranes, or non-intact skin, when handling or touching contaminated items, or when performing certain vascular access procedures. Disposable gloves are single-use gloves that must be replaced as soon as practical or as soon as feasible when contaminated. Disposable gloves may not be washed and reused. Now, you might think plastic film food handling gloves, right? Well, those are not appropriate for use in exposure-related tasks. If your workers have an allergic sensitivity to certain gloves, OSHA says you must provide hypoallergenic gloves, glove liners, powdered gloves, or other alternatives.
All right, great information there, Tricia. So let's move on to contaminated. Contaminated means the presence or the reasonably anticipated presence of blood or OPIM on an item or surface. Contaminated items or surfaces can expose workers to blood or OPIM if the contamination is not detected or removed. If a worker has cuts or wounds and a contaminant permeates through the PPE, or if the PPE has even a pinhole, the bloodborne pathogen has a direct path to enter the body. The goal is to keep contamination levels as low as possible. All equipment and working surface shall be cleaned and decontaminated after contact with blood or OPIM. You may be able to wipe up a blood spill with toweling, for example, but you still need to render the surface safe, and that means a disinfectant is needed to kill bloodborne pathogens. Decontamination is the use of physical or chemical means to remove, inactivate, or destroy bloodborne pathogens on a surface or item to the point where they are no longer capable of transmitting infectious particles, and the surface or the item is rendered safe for handling, use, or disposal. And OSHA says 4 types of substances are appropriate to decontaminate contaminated surfaces, and we have listed those here on the slide. The standard uses the term regulated waste to refer to the 5 types of waste which require special handling. If your waste does not meet any of these categories, you don't have regulated waste. Some items mention the potential for release. Under no circumstances should waste be squeezed or shaken to determine if it's regulated. And the amount of blood is not a good determining factor because, just as an example, 10 milliliters of blood on a bed sheet would appear as a spot and not be regulated waste, while that same amount on a cotton ball would cause dripping and would be regulated waste. We get questions on bandages, facial tissue, and feminine hygiene products, but in most cases they would not be considered regulated waste because these are intended to absorb the blood so it's no longer in a liquid or semi-liquid state and would not be released. Contaminated sharps means any contaminated object that can penetrate the skin. If a sharp is not contaminated with blood or OPIM, it's not regulated waste. Box cutter blades that are dull but not contaminated are not regulated waste.
Okay, so contaminated sharps containers are made from a variety of products, from cardboard to plastic. As long as they meet the provisions, OSHA will find them acceptable. Ensure that the sharps container is close to where sharps are used or anticipated. And if a worker must travel to a remote location to discard a sharp, it will increase the possibility of an accidental needle stick or improper disposal. So always place these close to where the sharps are used. So overfilling of sharps containers is a violation. So use a sharps container that has a transparent window, or place the container at a height that allows you to see inside the container. You're not required to provide a sharps container to a worker using lancets or insulin syringes for personal therapeutic reasons. However, you could require, you could require that all workers who have that situation to discard, use personal lancets or syringes, require them to bring to work their own special sharps container. And finally, uncontaminated blades are not regulated waste. They're uncontaminated, right? But you can place these in a puncture-resistant container labeled uncontaminated sharps, and that way no one will get cut. For all your other regulated waste, like contaminated rags and PPE, you'll use a regulated waste container as described on this slide. Disposal of regulated waste must meet applicable regulations of the U.S., states and territories, and political subdivisions. Federal EPA does not have regulations for the regulated waste we're talking about today, regulated waste disposal. So you'll need to refer to your environmental regulations of your state or territory. And states and territories may use other phrases like medical waste or infectious waste. Your waste hauler may have suggestions too.
Contaminated laundry is laundry which has been soiled with blood or OPIM or may contain sharps. The CPL and interpretations say that clothing manufacturers' instructions should be met and CDC guidelines are available. The CDC guidelines offer two choices listed on the slide. Workers may not take contaminated laundry home. It's the employer's responsibility to launder any contaminated laundry or PPE, but you can have a contractor do it. Just make sure the containers of laundry are labeled or color-coded. If uniforms are intended to keep blood or OPIM from passing through to the worker's clothes, undergarments, or skin, or if the uniforms are contaminated, then the employer is responsible for laundering it. Here we depict the universal biohazard symbol legend as it appears in the OSHA regulations, as well as a diagram of the symbol that appeared in the Federal Register back in 1974.
That's right. So a warning label. And by the way, lots of great questions coming in. If you have your question, now is the time to submit it to the Q&A box. We're pouring over those at this time. So a warning label must be attached to containers of regulated waste, refrigerators, and freezers containing blood or OPIM, and other containers that you use to store or ship blood or OPIM. The label has to be fluorescent orange or orange red in color and have the biohazard symbol followed by the word biohazard in a contrasting color. For contaminated equipment that's ready to be serviced or shipped, you'll attach a label with the statement about which parts of the equipment are contaminated. There are a few exceptions to labeling, and they're not required when red bags or red containers are used. Regulated waste that's been decontaminated by incineration, autoclaving, or chemical means prior to disposal is not required to bear the label. Before the waste has been decontaminated, though, it's still regulated waste and must be labeled or color-coded. If universal precautions are used for handling all soiled laundry, the employer may use an alternative color or label for the containers as long as all workers are trained to recognize them. And when or where there's an overlap between the OSHA and DOT required labels, the DOT label for infectious substances will be considered acceptable on the outside of the transport container, provided that the OSHA mandated biohazard label or red color coding appears on any internal containers which may be present. Biohazard signs, are required at the entrance to work areas, at HIV and HBV research labs and production facilities under 1910 to 1030. For all other workplaces or areas of the workplace, you'll follow 1910.145 for biological hazard signs, which have a biological hazard warning to signify the actual or potential presence of a biohazard and to identify signs or things that contain or are contaminated with viable hazardous agents. Now, the biological hazard tag is used to identify the actual or potential presence of a biological hazard and things that contain or are contaminated with hazardous biological agents. And by the way, tags are used to identify things that are out of the ordinary, unexpected, or not readily apparent. So that's when you'll use a tag.
Post-exposure evaluation and follow-up requirements. These only involve employees with occupational exposure, not Good Samaritans. Following a reported exposure incident, you need to make a confidential medical evaluation and follow-up immediately available. An exact time is not given, but OSHA requires this as soon as possible after exposure. If access to care is delayed, it may be a violation. OSHA trainer materials suggest that treatment should begin preferably within 24 hours and no later than 7 days. The exposed employee is the one who suffers the exposure incident. The source individual is an individual, living or dead, whose blood or OPIM may be a source of exposure to the employee. Post-exposure prophylaxis may include not only medications, but also any needed vaccination. You also need to make counseling immediately available to the exposed employee. Counseling concerning infection status, including results of and interpretation of all tests, will help the worker understand if the potential risk of infection and make decisions regarding the protection of personal contacts. After the exposed employee evaluation, you'll receive a copy of the healthcare professional's written opinion, which tells you whether vaccination was recommended and provided, and that the worker was told about diseases that result from contact with blood. Any other diagnoses won't go to you. These are confidential. So be sure you give a copy of the opinion to the exposed employee within 15 days of the evaluation. All the elements listed in paragraph C of the regulation must be included in an exposure control plan. But if a plan element does not apply to you, include it in your plan anyway, but state directly that the element does not apply to your company and explain why. You can keep the plan on paper or electronically, but workers must be able to access a copy during the work shift. If a plan is only on computer, workers must be trained to operate the computer. According to the CPL, safer medical devices are generally one of 3 types as listed here. Annually, be sure to document in your plan that you have considered any safer medical devices that are appropriate, commercially available, and effective. Another term in the plan requirement is direct patient care involving sharps. For years, this was a gray area, but for the mostly withdrawn regulation at 1910.502, OSHA had defined that as hands-on, face-to-face contact with patients for the purpose of diagnosis, treatment, and monitoring. Contact your local OSHA office if you'd like an interpretation as it pertains to your situation.
Thank you, Rachel. Yeah, I got a little a little happy here. I touched the screen and whoop, it went a few slides ahead, but we're back on track here. So the medical records you'll need are listed here. So For the italicized item, OSHA is looking for documentation showing administration of the complete 3-dose series. And if you cannot get a copy of the vaccination record, OSHA suggests documenting your attempts. And when these records cannot be obtained from the previous employer, you must obtain from the worker a written statement about vaccination status, including the dates, or where this is not possible, the approximate dates of the vaccinations. If the employer, if you claim one of the vaccination exemptions, that claim must be documented in the worker's medical record for the vaccination status. Now, get this, even the declination form is a record of the worker's vaccination status. So keep all these medical records for the duration of employment plus 30 years. Training records are not confidential, and they're kept for at least 3 years from the training date. Training records may be stored on site where they will be accessible for review.
And finally, OSHA calls for a separate Sharps injury log if you fall under 29 CFR 1904 record keeping. You can use the OSHA 300 for this as long as you provide the type and brand of the device causing the Sharps injury on the log, and you maintain your records in a way that segregates Sharps injuries from other types of work-related injuries and illnesses, or allows Sharps injuries to be easily separated. If you're not required to keep records under Part 1904, then you're not required to keep a Sharps injury log. Logs must be saved for at least 5 years. If this information is shared with other workers or management, you need to withhold the exposed employee's identity and any identifying information. Today, we covered over 70 terms related to the Bloodborne Pathogens standard. But before we move on to our Q&A session, we'd like to once again mention the sponsor of today's webcast, JJ Keller Training. Whatever your company's needs, JJ Keller Training can help with 24/7 access to hundreds of online courses and streaming video training across multiple industries. If you missed the opportunity earlier or joined us late, we are offering a complimentary white paper when you request more information on JJ Keller Training. Use the poll on your screen to select your interests, and we'll send you our Bloodborne Pathogens white paper. And now I think we are ready to take your questions.
Yes, excellent. Great job, Tricia and Rachel. Thank you for sharing your insights and your expertise. Before we do start the Q&A, just want to let everyone know about the evaluation survey that we're asking you to complete. The survey will open in a different screen after this webinar. Your input is very important as it helps us to improve our future webcasts. Once again, if you would like to ask a question today, just click that Q&A button at the bottom of your screen, type your question, and click the send button to submit it. If we don't get to your question today, all unanswered questions will be forwarded along to our speakers. With that, we'll start it off with a question for you, Tricia. This question asks, is it a requirement for there to be designated first aid personnel on a job site with expected BBP exposure? And it's saying under 29 CFR 1910.1030 or 1910.151, for instance.
Right. Thank you, Kevin. So the first aid requirements, this listener is correct. 1910.151 is the regulation that you would take a look to see what your first aider requirements are. See, the bloodborne pathogen regulation does not require first aiders. It just requires you to protect your employees with occupational exposure, whichever duties and whatever they do. But back to 1910.151, you'll see paragraph B says, in the absence of an infirmary, clinic, or hospital in near proximity to the workplace, which is used for the treatment of all injured employees, a person or persons shall be adequately trained to render first aid, and then it goes on. Now, when you look at this literally, it just says you need to have someone trained to render first aid. It doesn't say you need to designate anyone to handle first aid. And there is a letter of interpretation to that effect. It basically says they're taking this regulation literally and saying OSHA only requires, when you're not in that near proximity, to have someone trained. But you do not have to force or designate anyone, to those folks who are trained, to actually perform the first aid. That is entirely up to you, according to OSHA. So a little tidbit there, and there is a letter of interpretation on that. So great question, Kevin.
All righty, thank you. Well, the next question as we move on, it asks, is there any any quantity limit to call it a regulated waste? If we are addressing a first aid, we might generate a little bit of waste contaminated with blood. Do we have to use an approved agency to dispose of that waste?
Okay. All right. So kind of a two-part question there, the quantity issue. When you take a look at the definition of regulated waste, I'm going to scroll down, you'll see a number of examples, or they're not really examples. These are the regulated waste. And a couple of them are kind of interesting and kind of tie into that first aid scenario. One would be, it means liquid or semi-liquid blood or other potentially infectious materials. Liquid or semi-liquid, think about that. Is it drippable? Is it squeezable? Of course, by all means, do not shake it or drip it or squeeze it or anything like that. In your judgment, is it drippable or squeezable? And then the second one, contaminated items that would release blood or OPIM in a liquid or semi-liquid state if compressed, that's squeezable. And then items that are caked with dried blood or other potentially infectious materials that are capable of releasing these materials during handling. That's the flakeable scenario. Would it flake off if you shook it, but don't shake it. So the quantity issue is there's no hard and fast quantity. It's these subjective things that we're talking about. And that CPL 02-02-069 goes over that scenario and the definition of regulated waste in greater detail. It talks about a cotton ball, for example, with blood on it versus a bed sheet with blood on it. It might be a spot. This small quantity might be a spot on a sheet, but drippable on a cotton ball. And so it all is pretty subjective there on quantity and whether it's a regulated waste. And as far as that second part of the question to deal with, do you have to have an approved agency to dispose of those wastes? The disposal itself is, it has to do with your environmental regulations. The OSHA passes the buck. It sends you over to your state and territorial regulations for disposal. So you'll need to take a look at your own environmental regulations, your waste regulations over there to see if your state calls for special disposal. From an OSHA perspective, if it's not regulated waste by definition, but from OSHA's perspective, you could put it in the regular trash. But again, you need to check your environmental regulations to see if that truly is the case.
Okay, thank you. Next question asks, is a sharps injury log required to be maintained in circumstances where sharps are not used and or if there have been no sharps related exposure incidents?
Okay, this is a great question because I had this question way back when this the rulemaking or the regulation was changed early on, oh gosh, 20 years ago with this sharps injury log. If you indeed have absolutely no sharps and don't anticipate any sharps injuries, and you have no sharps injuries, you could literally put in your written plan something to the effect that, well, we don't use sharps, we don't foresee sharps injuries, therefore we are not keeping a sharps injury log. But the moment you do have a sharps injury, you have folks who have occupational exposure, you fall under the rule, you're going to need to have that sharps injury log in place if in fact you fall under Part 1904 and have to keep those injury and illness records over there. That's kind of the two-part there. So the sharps injury log is not required if for some reason you are exempted from keeping injury and illness logs over in 29 CFR 1904. I hope that makes sense. Complicated answer there, I suppose, but a great question.
Staying with sharps, this question says that I manage an office environment. Are we required to put up sharps containers for employees in the restrooms? And also, what about volunteers?
Okay, so sharps injury logs are sharps containers in the restroom. That has to do a lot of times with the you know, if folks, your employees have personal use of needle sticks and they need to dispose of them, you are not required to provide sharps containers for personal use needle sticks. You can ask that your employees bring their own personal sharps container to work. I think that answered the question.
All right, thank you. Next one is asking if you could please provide some clarification on what's required in a general industry manufacturing plant. The questioner just says that in their interpretation, the standard seems to apply mostly to hospitals.
Right. This gets back to the definition of occupational exposure, and the OSHA regulation 1910 to 1030 applies to general industry and shipyards, right? It doesn't narrow it down to healthcare or hospitals. So from a manufacturing setting, you would look at the jobs and duties of your workers and determine whether they have occupational exposure. Again, that is reasonably anticipated contact with blood or OPIM as part of their duties. And so in a manufacturing setting, possibly you could have folks that are designated first aiders, whether that's collateral duty or full-time duty, whatever, or maybe you have folks in your manufacturing setting that would be designated to clean up blood spills if someone were to have an accident and there's a spill of blood. Those are just two examples. Maybe you have security guards who are have that first aid role in that in some scenarios, and so they too might be covered by the rule for occupational exposure. So you kind of got to look at the jobs, not at the industry. Okay.
Thank you. Next attendee has a question for Rachel, and he asks, who has to train the temp workers? Is it the staffing agency or the client?
That's kind of that's a good question, because it does kind of break that out into two different pieces here. An OSHA letter of interpretation kind of does break this down. It says that the contractor who would have the relationship with the worker, they would provide training on generic training on universal precautions, any required vaccinations, and any follow-up evaluation after an exposure incident. But your host employer, that's the person who would create and control the hazards and the exposure that the person may have. They would provide the site-specific training and PPE, and they'd be responsible for controlling exposures. So really, though, who has to do what, that depends on which employer creates or controls the hazards, who can correct them, and who exposes the worker to the hazards. So in the end, it's really a shared responsibility. So great question there.
Thank you. There's another for you, and this one asks, does OSHA exempt small employers for bloodborne pathogens requirements?
No, there's no requirement. That really just depends on the occupational exposure. There's no number of employees that I'm aware of, and so it would just really hinge on that occupational exposure definition.
Okay. Thank you. Have a few more questions still out there. This one asks, what about employees with spill cleanup as a collateral duty? The questioner saying is they're understanding they're not first aiders, but is there a loophole for them with the vaccine?
Okay, I've got that one. So yeah, we talked about the vaccination, what I call a loophole for collateral duty first aiders. That's for collateral duty first aiders only. So this loophole or violation without a penalty loophole, it does not apply to those with other collateral duties involving blood or OPM. So your employees that clean up blood spills as a collateral duty, they have occupational exposure, and they will require that vaccination to be made available, within the 10 days of initial assignment, unless they are exempted.
Okay, thank you. No, we're winding down now, and you both have covered lots of ground, been very thorough, but anything left unsaid or any closing thoughts as we get wrapped up today?
Sure. Just one thing, the heart of the regulation depends on occupational exposure. And once you have one or more employees with occupational exposure, the rest of the rule comes into play. We get a lot of questions on training, because once your employees have occupational exposure, one of the first things you're going to do is train your employees with occupational exposure, so that they learn about the vaccination. They learn all about all the other ropes. They will be in a good spot to use all their training right there in the plant, right there at the site, and put that to practice. So great. Thank you. Great.
Oh, absolutely. Anything from you, Rachel?
No, I think Tricia summed it up very nicely there. It all hinges on that definition of occupational exposure. So not so much the industry, but the question of exposure.
Okay. Well, again, we thank you both. Unfortunately, we have run out of time today. We're sorry we didn't get to everyone's questions, but again, all of today's unanswered questions will be forwarded on to our speakers. And once more, please be on the lookout. We hope that you do take the time to fill out that forthcoming evaluation survey and give us your feedback. With that, we end today's Safety and Health Magazine webcast. We'd like to thank Tricia Hodkovich, Rachel Krupsak, everyone at JJ Keller, and all of you who listened in. Thanks and have a great day.